And then really in 2015 is when the big change came and all the new drugs became available. Our carfilzomib, Nilaro, panobinostat, daratumumab, and then there's loads of other drugs coming down the line like CAR-T, Venetoclax, and there's lots of reason to have hope, and I think it's really important that we do all have hope. And to know that all these drugs are available is just brilliant for patients. So what is our... It's not moving on, Mark. Did we skip one there? Yeah, sorry. So the mission statement of Myeloma Ireland is to inspire hope, promote awareness and contribute to health and well-being by providing support to every patient, carer and healthcare professional dealing with myeloma through education, advocacy and research. Sorry, I know why they're not moving. Yeah. And I suppose the most important thing is that myeloma patients and their relatives and family are central to everything we do and believe in Myeloma Ireland, and everything else that happens around you. So we provide information, we promote research. Research is a huge part of what we do. We support all the support networks that are necessary. We raise public awareness, and that's really important because I'm sure when many of you were diagnosed, a lot of people around you never had heard of what multiple myeloma was, and that adds to the stress and the worry, and it nearly makes it seem more serious because nobody knows what it is. When in actual fact, you see the room today, there's loads of multiple myeloma in Ireland, but the awareness just isn't there. So that's why days like today are really important. And education at all levels. So support groups, we have support groups all around the country, and these are an invaluable source for patients of support, education, just a chat, a cup of tea, speakers, and there's a list there of where we have support groups. The most recent one is Cork, that's just starting off. And I encourage you, if you're not part of your local support group, it's really important that you should try and link in, because that's where you'll get the best support from one another. I'm involved in the support group in Sligo, and patients get to know each other so much better through the support group and outside of the hospital and in the support centres. And they're just a really great source of, and you become friends. And I know in our group they meet outside for coffee, and when things go wrong or things go right, they have each other to support, because nobody understands better than yourselves. And just a little bit about Myeloma Patient Europe. So in the last year we've partnered with Myeloma Patient Europe, and they're an umbrella organisation of myeloma patient groups and associations from all across Europe. So it's great that the Irish board now are part of the European network. They provide education, information and support to member groups and advocates at European levels for the best possible research and equal access to the best possible treatment and care. And for us to have a voice at a European level is really good for Irish patients. We're very fortunate that one of our board members, Fionnuala Duffy, who's also a myeloma patient herself, she's here, yeah, is currently undertaking the Advocacy Development Programme with Europe, which educates advocates on myeloma and its treatment, drug development processes and the basics of evidence-based advocacy. And then Fionnuala will then be an Irish advocate in Europe. As part of her training, she will be going to EHA, to the European Haematology Association in Vienna next month. And they have a great website and loads of great information and fact sheets if any of you want to log on to the website. And Fionnuala's here today and is happy to chat to anybody who wants to talk to her about it. One of our biggest projects during COVID was we developed podcasts around the area of myeloma. I think we have a helpline on our website, and during COVID we were getting a huge volume of calls, an extraordinary amount of calls from patients looking for support, not understanding what was going on, not understanding transplant, just really, really struggling. And it was getting to a point where we actually had a meeting about it because we were quite concerned. And there was many reasons for this. It was staff shortages in the hospital. A lot of the nurse specialists were being pulled from specialist roles to go to the front line. You weren't allowed to bring anybody with you. That was the biggest issue. Patients could not bring somebody with them, and they were given all this information and trying to accept what was happening and try and absorb all this information, and then going home to somebody who's really stressed at home, as with half a story, as they say. So it was causing awful stress. So Mary Kelly, my nursing colleague, came up with this brainwave that we develop podcasts to put up on the website and try and provide as much education as possible. So we developed a number of podcasts, and they're all up on the website. They're also available on Spotify and Apple Store. And if you haven't listened to them, I'd encourage you greatly to listen. I've listened to them a few times, and I still learn something new every time I listen. There's patients, there's carers, there's consultants, dietitians, there's all sorts, psychologists, and they're really, really good to listen to. There's one on transplant as well for anybody who's facing into transplant. We couldn't do any of this without our donors and fundraisers, so I just want to say a huge thank you to everybody who's fundraised. It's been difficult during COVID, but people still were fundraising in the background. Janssen staff, which is one of our pharmaceutical companies, did a work step challenge and raised 2,000. Ali Byrne, who's here in the audience today and is going to be speaking later, has been doing phenomenal fundraising. I think half the Midlands had to shave their heads, and there was a huge night. I don't know how many of them in the end, and a lot of fundraising efforts around it, and she raised 7,500 and did huge awareness and public awareness around myeloma in the Midlands and on social media. And then Damien Leonard is a young man, I don't know if any of his family are here today, who ran the Manchester Marathon and raised €5,000 there recently. And then several anonymous donations through the website. What do we use our funds for? So we provide research grants for doctors doing research in the area of myeloma, registrars and students, through the consultants and through the hospitals and the College of Surgeons in Trinity and different places. And without this money for them to do their research, they wouldn't be able to do it. So that's invaluable. We have rebranded our website and our merchandising in the last year or two, and that was all funded through Myeloma Ireland. We have a medical writer, Danielle Byrne, who's here today, who regularly does interviews with different people of interest and puts them up on the website, and sometimes they make it to the newspapers, and that's also great for raising awareness. We've media campaigns, we help support the support groups, we give money to the centres that hold the support groups, we give a donation towards the tea and coffee, and if they want to bring in outside speakers, we'll pay for the speakers. Board expenses are very minimal, we're all volunteers, so it's really only travel would be the main thing. Information day, days like today we can run free of charge through the funding. Logistical support, Sinead and Brian, or Mark, who we couldn't do it without them. And then our Wild Myeloma Way cycle is our annual big event, and we're delighted it's happening again this year in September. It's the Wild Atlantic Way, but we call it the Wild Myeloma Way. This was the last one in 19, I think. We left from Galway Hospital. That's Professor Hyatt there and Professor O'Dwyer. They didn't cycle, but anyway, they stood in for the photo. That's Mary Kelly on the bike, and that's Mary and David. So it's a fantastic weekend. It's a 2-day event. Patients do it, relatives do it, pharma do it, healthcare professionals do it, and it's a wonderful weekend. So this year we're going from Limerick University Hospital, starting on the Friday morning, going out to Spanish Point, staying in Spanish Point, and then back into Limerick the next day. And it's for anybody who's interested in taking part. It's a wonderful weekend. What's ahead? Well, our Wild Myeloma Way cycle. We will again be doing our education grants, podcasts. If we find something of interest, we'll keep developing those. We've been put forward for the Irish Podcast Award for the Best Health or Wellbeing podcast, so we're waiting to hear about that. We're already starting to plan for next year's Family Day, and if any of you have any suggestions for speakers, please let us know. We're always trying to form new support groups. We're in the process of trying to set one up in Galway, because there's a huge need for one there. And then our AGM will be in December, and if anybody has any interest in attending, just send us an email. And I'm going to finish there. We're very active on Facebook and Twitter, and everything that's happening will be up there, and our website is really busy as well, and there's lots of information up there. Today's talks will be up on the website, so we'd encourage you to look at them. And I'm now going to introduce our first speaker, Professor Paul Brown, who's a great friend of Myeloma Ireland and a huge advocate of myeloma. He's been an advisor to the board for a number of years now, and he's going to talk to you this morning about myeloma, and I'm sure you're going to get loads of information from Paul. Thanks very much.
Well, good morning, and it's a little even for me when I take this mask and take it off. I'm still trying to get around that. It's fantastic to meet so many people, family, friends, and others living with and myeloma, and know every time you've met me or any of my colleagues in the last 3 years, it's been with this on. So it's actually nice for all of us psychologically, I think, to be able to do this. And it may come up in the discussion during the day, because I think there are still ongoing considerations and discussions about what we've learned from COVID, how we should deal with it, and what the implications are. And it's probably an important topic to come back to. It's a real pleasure to be here. I can't believe it is nearly 3 years. I think it was September 2019. I was just checking, and Mary will verify, when I had the privilege of being at this meeting with Myeloma Ireland, and it's fantastic to see what's happened in terms of the work despite the challenges of COVID. And so for the next 20 minutes, and I want to be reminded to stop, I thought it would be just useful, and in fact some of you who may have been at a previous presentation will spot that I have used some of the same slides, and I don't make any apologies for that, because I think, as we just heard from Ger and others, there's so many challenges that for each of us it's worth rethinking things we sort of know about and maybe trying to add some new information to that in terms of the myeloma experience. But I have obviously made some changes and to the colour scheme as well as I go along. Simple things, and again, I'm very conscious that in the room some people know a huge amount and some people know less, and so those of you who are very knowledgeable, bear with me, and where I go off on a tangent, as I say in the questions, please come back to me. But myeloma, when most of us hear about this, if we've never heard of it, people think, is that melanoma, or is it some other cancer, or what is it? So it's a bone marrow disease, as we've all learned, and it is important to think about the normal bone marrow, and you can see in the picture we think of the seed or stem cell in our bone marrow, whose job is to make blood cells. Red blood cells, white blood cells to fight infection, and platelets. They're the ones we don't know quite as well, but they're to protect us from bleeding, and they help our blood to clot. And what happens in myeloma is one of those white cells, the plasma cell, goes wrong. And this is a picture from a bone marrow sample taken from a patient living with myeloma, and all those largish blue cells where they're dark blue at one side, and you can see what we call the nucleus. That's the center, the nerve center, if you like, of the cell at the other part. Those are actually myeloma cells. And the thing is, they actually come from a normal white cell that we actually use to fight infection. And funny enough, during COVID, we've all learned about the need to make antibodies to fight an infection. And normally, those antibodies are made by plasma cells. And actually in myeloma, it's the plasma cell where the program has gone slightly wrong and has built up and is not functioning correctly. So it's very central to making antibodies and fighting infection. Many, but not all, people or patients who've had a diagnosis of myeloma may have started with pain, particularly in their back, and often they'll, as many people know, they might have thought, oh, I pulled a muscle, or I hurt myself, or I don't remember how it happened, and they may have seen several healthcare professionals, and with the best will in the world, and often it takes some time to come to a diagnosis. But very often, in those people who have had damage to their bones with myeloma, you see evidence of some form of what we call a fracture. And that's a scary word. If somebody says, my back is broken, or I have a fracture in my spine in particular, or in my leg, or in my hip, it's a very scary thing. And sometimes it's hard to get across. And I remember when I started a long time ago in caring for myeloma, there was still a sense if you broke your back, you had to lie in bed for weeks. And of course, this was the worst possible advice, particularly with myeloma, because by limiting your mobility, the back bones and all of your bones got weaker and weaker, the calcium leaked out, and you didn't do so well. So one of the big things we've learned over the years is, even though, I've got a fracture in my spine, the best possible thing is, once the emergency issues are dealt with, is to get moving, get active, and maintain mobility. But this is a challenge for some, but not all, people living with myeloma. Big question, we wish we knew the answer, and there is so much research and development. We're very fortunate to have outstanding colleagues in the room who are very interested in this area and who will bring this field forward. But, what causes this disease? We don't really know. We know there may be links with environmental factors, radiation exposure. We know there's something about the immune system. I've already said that myeloma cells come from the B cell immune system, the one that makes antibodies. And we know that in some situations, if your immune system is not working correctly or is stimulated or overstimulated in a different way, eventually a change can occur and allow the myeloma to develop. But we don't really understand that. But it's very important in thinking about the newer, exciting treatments that are coming through. An important question that I often get asked is, does this run in my family? Or could my children get myeloma if I have it? Or is there a risk? There is in some studies, and the Scandinavians in Sweden and Norway in particular, and Finland have done very good studies, and also in some parts of the United States, where you might see one member of a family as myeloma, another member of the family might have a certain kind of lymphoma, another member might have MGUS, which, as some people in the room will well know, is like a precursor to active myeloma. True genetic myeloma is uncommon, but there is sometimes areas where you have families with exposures. And that could be, of course, you have seen situations where partners or a husband and wife actually get myeloma, and you begin to say, well, what's the environmental factor in that situation? So there's a lot we still need to learn about why this condition develops, and there's a lot of good work going on. I think we just already heard, I mean, in terms of in Ireland, how common is this disease? It is still classified as a rare cancer, and that's important not only locally but in Europe in terms of us getting recognition and funding for new developments and new treatments. But I just updated some of the information in Ireland from the Irish National Cancer Registry to give us a sense of what's happening with myeloma. And you know, these numbers can vary a little bit, but at least 300 people each year in Ireland now receive a diagnosis of myeloma. Depending on precisely how you do these numbers, it could be a bit higher actually. But broadly speaking, somewhere between 300 and 350 people each year. It's slightly more common still in men than women. The average age at diagnosis is young. It's 65, and I say that very deliberately. And in fact, it's really important to emphasize that in Ireland, 2/3, that's 67 to 70% of people living with myeloma and living well with myeloma are over the so-called age of 65 and expect to live well for 20 years if we get this right over the next 20 years. 1/3 of people with myeloma are under the age of 65, and that's broadly the breakdown. It is, as I said, rare. If you look in Ireland, it's approximately 2% of all cancers. But the really important bit, and the good news story, if you look at the Irish Cancer Registry information, which doesn't always get put out there, is we now have thousands of people, actually, it's hard to believe this, but it's true, several thousand people alive and living well with myeloma. So although there are 300 people diagnosed each year, but whereas if we went back 15 or 20 years, sadly, that was not the case. So we've clearly made, and we can see this from the information, don't have time to go into today, from the Irish Registry, that we have made huge progress in outcome, survival, and extension and improvement for myeloma. In fact, it's the biggest of all the cancers in the Irish Registry over the last 5 years. The biggest real success in the long run has come in myeloma. So although it's a rare cancer, we're clearly making progress. That's important. The tests that those of you who've had to go through this will be aware of, there's lots of tests, but obviously part of the problem is in the bone marrow, the factory where, as I said, you make your blood. So a bone marrow sample will have been obtained. It will show that picture I showed you, will show these plasma cells. The x-rays, and nowadays that will be not simply plain x-rays, but will usually be some form of either an MRI scan or a CT scan or a PET-CT scan or some other sophisticated set of pictures taken of all of your body or all of your bones, depending. Blood tests, as we all know, are very important, and we can monitor the antibody protein that doesn't work but is a good marker, a signal, the so-called paraprotein or the M or myeloma protein or the protein in my blood, or whatever way each of us understands that test, but it's a very useful measurement. It's really important if in this room people are chatting and, well, my protein was 10 and someone else's mine was 2 and someone else's mine was 20. In fact, in all of those cases, for that individual, that number, it doesn't mean that the 20 is worse than the 10, which is worse than the 2, or necessarily vice versa. It's a highly individual number for each person, and how it's interpreted is very important, that that's put into context for that individual. And that's an important point, because sometimes people, understandably, will focus very much on what is that number. We also have, as people will know, more sophisticated tests now, the so-called light chain test, which has really been very helpful in the serum. And that's largely replaced what we used to do, which was to collect urine over 24 hours and measure Mr. Bence-Jones's protein. Henry Bence-Jones originally was the first person to spot the unusual light chain protein in the urine before they really understood what it was. And that was, I was going to say in the last century, it was actually in the century before the last. In practical terms then, just don't too many technical things, but normally we have, if you look at this picture, starting at the top left, we have the healthy plasma cells. They're the B cells that make antibodies. In myeloma, which is in the picture just below, I've already shown you a picture of those cells gone wrong, so to speak. The program is altered, and they still make an antibody, but it's a redundant antibody, which is this paraprotein or M protein. And then we can also measure, which is a part of that protein, the light chains. So these are the tests, as I said, that are very useful in seeing, A, making a diagnosis, and B, seeing how people are doing when they're on treatment. We mentioned scans, and I just put these pictures up not to get too bogged down in the detail, but on the left two boxes at the top and the bottom is an old-fashioned, ordinary X-ray of hips. And it's still actually a very important test sometimes in certain situations. The picture at the top is before treatment, and the picture at the bottom is after. And I don't expect anyone in the room to be able to see this, and I can't really see, but there's really no difference. So on the plain X-ray, you cannot say to somebody who's come into you to say, how am I doing? You can't really tell if they've improved. That's the point I want to make. The middle two pictures are actually a form of what we call an MRI scan. And if you see where the arrow is at the top and the bottom, most of us can see there's a kind of a white thing, a white spot there if you look where the arrow is at the top, and it's still there at the bottom. Now that, if you come in at the bottom, which is 168 days after you started your treatment, and your protein has come down and your light chains have gone back to normal, and you're feeling much better, and then they say, oh, here's your MRI scan, you can feel, oh dear, that's disappointing because I still see a spot on my MRI scan. And that's a problem. So even with MRI, it can be difficult. Now, some of you or many of you will know some of our current experts in MRI are so good that they can actually draw a lot of information out of an MRI scan over and above this. But what's really taught us a lot, I'm going to show a picture on the right here. So this is the newer generation of scanning using what's called PET scanning. And again, if you look where the arrow is at the top, you can see there's a kind of, again, a white blob with a sort of a red or pink line around it. And that's where the myeloma activity was at the beginning, and then at the bottom, if you look where that arrow is, which corresponds to the MRI, that white blob is more or less gone, or the signal has gone away. So this is what we call a functional measurement. It tells us that the active myeloma has gone out of that spot. So even though you still have a spot on your ordinary X-ray and on your scan, the active disease has gone away. And that's the advantage of what's called a PET scan. So I don't want to get into too much detail, it's just to give a flavour of some of these tests and how we look at them. And this is another way to see a whole body picture of a PET scan. And obviously this scan was taken at the beginning of somebody's course in living with myeloma. And it is a bit frightening because you see a lot of white spots. And this is a question I'm often asked is, why is my disease, some people say it's myeloma or is it multiple myeloma? And which is worse, or are they the same? And truthfully, I personally think myeloma is the term in broad, and multiple is simply an older term that says there's areas of disease at more than one location. It does not mean, and this is really important, it does not mean that your disease is worse if you've got 2 or 3 or 4 spots necessarily, and that's really important to sort of understand. So this would be a typical picture of anybody who has a diagnosis of active myeloma at the beginning. And what you want to see happen is all those bright white spots in this picture go away and aren't bright after the treatment. That's the important point. The last of the kind of technical things, and I know again in this room there are people who are very good scientific and have taught themselves and have to, and they've learned all about my chromosomes or my genetics and what's the relevance in myeloma. I've already said that this is important. This is not normally a hereditary disease, but we absolutely see changes in the DNA or in the chromosomes in myeloma. And some of these are linked to, I suppose, a more complicated course. And again, this is where medical and scientific terminology can be actually quite unhelpful, because when the studies are done, they'll break it up and they say, oh, this is good risk, and this is bad risk, or this is good risk, and this is high risk, or this is intermediate risk. In reality, actually, when you look at how people are doing now with modern treatments, a lot of that terminology actually isn't that helpful. But there are certain markers where you would say, look, we're going to have to think about the best choice of medicines for the perhaps, and keep them going in a different way to what we do normally. And again, I do not want to go into the detail of these, but there are some people perhaps who've heard of these terms, and there are certain of these chromosomal changes that I've listed here, such as sometimes it's called a P53 or chromosome 17 or whatever, or chromosome 1, and that's a particularly confusing one actually, and a lot of the time doesn't actually make a difference to your treatment. But the point is that there are these detailed changes, and for any individual these can be studied in great detail. They're incredibly important, and I know we may hear more from Siobhan later and others for certain new developments that are coming in myeloma treatment. So once the diagnosis is made, the first question actually before treatment is actually getting a sense of just trying to get your own head and your partner and your family's head around this and taking some time to do that and actually dealing with whatever the urgent issue was. If it's pain, that has to be fixed first. If it's having an infection, that has to be addressed. If it's the shock and trying to just process that information, that has to be addressed. But obviously, an early question is, well, what are we going to do? What's my treatment? And a weird part of this is you're suddenly told, I have myeloma, I've looked this up, this is bone marrow cancer. A lot of what you might see before you got the wonderful resource actually of MMI and similar resources across the world is quite negative because older information will say this is a bone marrow cancer. They use words like cancer. They use awful words like incurable. And to get that one out of the way, I mean, the problem is when you read about these things, these sort of terms are sometimes used. And of course, diabetes is incurable. Many other diseases are incurable. But of course, the objective is to provide a plan of treatment into the very long term so that people can seriously say, I'm going to be around and living. Yes, I'm going to have treatment, but living with this disease over the next 20 years and beyond and bringing in new treatments as they come true. So the truth is treatment is necessary for most people with active disease. But there are people who will have a diagnosis of myeloma where after a lot of thought and discussion, the plan will be not to treat them initially. And that can be quite hard to work out if you have what's called asymptomatic or smoldering myeloma. And there are guidelines, there are ways that we can all discuss that and advise. I don't want to go into too much detail, but just there is a kind of several people have different, I suppose, locations on a spectrum. And it doesn't mean if you're on the red or the green end or the blue end that it's better or worse. It's just the way these things are. But at one end of a spectrum is, I suppose on the left there is normal. At the other end is active myeloma where there's no doubt it needs treatment. The condition called MGUS or monoclonal gammopathy, which just means that protein that I mentioned, and US here is not, of course, US, it's undetermined or unknown significance. So this is a classic old-fashioned medical jargon where you hide behind a confusing term. But what it really means is that you've got this signal, the protein, you will have some plasma cells in the bone marrow, but not very many. And somewhat arbitrary, the cutoff might be 10%, let's say that's currently. But importantly, you've no bone disease, you've no problem with your kidneys, you've no sign of anemia, you've no infections, and you've no other, what I call it, signs that this is causing you any problems. So if you have MGUS, you don't need treatment and you will be monitored. But there is a small chance each year of that developing into active myeloma. The group in the middle I just mentioned are people who clearly have myeloma according to our diagnostic criteria, but interestingly may not require treatment. Now that's the current view, and in fact that may evolve because we've learned with virtually any other cancer that logically if we have good treatments, early diagnosis and early intervention surely makes sense. I think until recently in myeloma, that wasn't the way of thinking, but this area is rapidly changing, and common sense would suggest that if our treatment is not toxic and it's very effective, surely if you've made a diagnosis and you're doing well, would you not bring the treatment in a bit earlier to keep it well and stop it ever causing a bone problem or a kidney problem? And that's an area for open discussion and further development. So certainly treatment is required, as we said, if you have a bone problem, bone pain, if you've had infections, if you have a kidney problem, if your calcium is up, this is a slightly different point, if in that bone marrow picture I showed you, there's a high percentage. Now again, it's a sort of arbitrary cutoff, sometimes given like 60%, but it sort of depends a little bit on your situation there. That would require discussion with your medical team. And as I said, treatment is not normally required in MGUS. Like so many things, but so especially in myeloma, I already touched on the importance of maintaining mobility and getting if you come in first with a diagnosis, it's so important. People can be in very great discomfort, and as I said, they may have been some weeks or months before a diagnosis is made, and the trauma and the stress of that exacerbates that. So getting that aspect of your care quickly under control is really important. Fluids are very important. Extra couple of glasses of water every day protects the kidneys, stops those light chains blocking up the kidneys as they go through. Mobility we've just discussed. Prompt treatment of infection, as we've all learned, with antibiotics and even sometimes having a stock of an antibiotic or having a good arrangement with your own primary care, your general practitioner, or with the hospital, or whatever arrangement works for you, but making sure there's no delay in getting prompt antibiotic treatments. These are simple things, but they've made a huge difference to how we do overall with myeloma. And then naturally we want to think about, in this introductory overview and some obviously more detailed, I know, discussion during this whole day, is how do you specifically kill or get rid of the myeloma cells? And certainly when I started, unfortunately, we only really had the fairly blunderbuss or brutal, if you will, form of chemotherapy. And the development we still use from that era, and we'll come on to that, of course, is using high-dose melphalan chemotherapy for with stem cell support, the so-called stem cell transplant. And that actually dates back now 30 years. So that is, if you will, from that era of treatment. And we would actually like to get rid of that if we could. If we could remove stem cell treatment in its current form, that would be an advance. We're not there yet, and we can come back to that point in a minute. But yeah, that's perfect, 10, thanks. The new medicines, about which we'll hear so much more, I'll comment on in more detail. Radiation is still important in myeloma, certainly if you've got an area that's putting pressure on, let's say, one of your nerves in your back or in your spine, or an area that's going to cause, or in a particular area for bone, there's going to be a particular problem. And radiation is very effective, it actually works. We often see that, so if an area has had radiation, that area never causes a problem again, even if other areas do. So it has an important job, but it has to be part, it's not in and of itself the total treatment. And clearly the big development, as I said, this is a disease of the immune system. And I think what we've realized is cleverly manipulating the immune system is the way forward in not only treating myeloma, but hopefully aiming for what will be a functional cure over the next decade for many or most people. And this has been a revolution in this disease. There are some technical terms, and they'll be on the slide. I don't want to go into them here, but some, I think what's confusing sometimes is people say, I've had my treatment, am I in remission, or is my myeloma recovered? And for each person, what that means is different. There's a blood test that says you're in remission. There might be a bone marrow. It might be a PET scan. It might be a fancier residual disease test or DNA test or a flow test or some other test. But there is a practical definition that makes sense. Really important question is keeping yourself in remission and avoiding or not having to go on to a further line of treatment for as long as possible. And that's actually a very important, obvious and practical. Your overall quality of life. Your blood test may be good, but if you're not good, that's not so good. So we have to look at that and see, well, what can we do, even if the test is right, to improve quality of life? Side effects, crucial. Not everybody should receive the so-called same protocol. It might be for one person, how you give the Velcade should be different, or you don't give it, or the Revlimid is different, or whatever it is. And then the sequence. For you or for any one individual, do I get all the new medicines at the same time? Do I get one now? Should I keep one in reserve for 2 or 3 years? And some of these points will, I know, be discussed today. For the so-called younger patient, but let's say for a patient who's considering having a stem cell treatment as part of their program, this sort of little map, it's a road map, and the first 4 lines represent what they call induction, the first 4 or 6 cycles of treatment. Then you have a harvest, and then you have the high-dose chemotherapy with stem cell support. And the picture of the paraprotein, which is the blood test we monitor, goes down, you hope, in parallel with that. And you'll hear more, I know, later on, a little more about the practical aspects of some of these treatments. Nowadays, I think I've put up, there's lots of treatments, but I've listed, I think, the 3 main types of treatment that most people who are diagnosed with myeloma will get initially, of any age actually, but let's say first-line treatment choices. So in medicine, like the immune modulatory medicines like lenalidomide. We used thalidomide. Some people in this room I know will actually have had thalidomide, but of course it's not used very much now. But it was the breakthrough. Thalidomide was the breakthrough because we realized that if you use thalidomide, which previously had been taken off the market, sadly because of the tragic situation where mums had taken it in pregnancy and it had affected their children, But I recall very clearly when we started using thalidomide, it really was amazing to see people whose disease was very difficult beginning to respond in a way that we hadn't seen before. So we learned from thalidomide that if we could get better medicines, and that's what Revlimid is, and that's what pomalidomide is, and there's a whole range of other ones now coming on, they're all part of that family, what we call IMiDs or immunomodulators. So most people nowadays will receive this type of medicine, whether it's Revlimid or a cousin, in their treatment. The second huge breakthrough, again going back 20 years, as you said, was the so-called proteasome, big words, proteasome inhibitor. But this is the drug most people probably know as Velcade or Vortezumib. And again, we have at least 4 types of these now. But this would be in most people's program. And then still, despite all their side effects, and they are very challenging, most people do need some steroids in different ways. And it's a trick there is to minimize the side effects and how much steroids you get, but still get the piece of the steroids that's beneficial. So that's the sort of framework treatment. And what is amazing to some of us who've been around myeloma for a long time is you can now treat somebody for 6 months. Basically, the lenalidomide is obviously a tablet as an outpatient. Unfortunately, still the Vortezumib is an injection, although it's logistically should be possible for that to be done outside the hospital setting. And the steroids are obviously a tablet. And none of these are what we would have known as chemo or chemotherapy in the older sense of the drug, of the term. And for example, none of these medicines would cause hair loss, for example. So this is a big development that you could actually treat successfully myeloma and not use any of the chemo that we would have started with. These treatment programs often have nicknames, if you like, or code names, which can be confusing, but RVD is often quoted, and that's the one with Revlimid, Velcade, Dex. Some people may have received a previous version with thalidomide, and that was called VTD, where you had Velcade with thalidomide and Dex. Some people may have received at the start something known as Cybord, which is actually combining another older chemo medicine, cyclophosphamide, which is still very effective in myeloma, particularly when given at a low dose in combination. And the low dose minimizes the side effects. And in fact, our colleague Michael Dwyer in Galway has done, and Siobhan here, have done a huge amount of work in sort of trying to work out why that is helpful at a low dose, and it's been very interesting. So we mustn't forget still that the older chemo medicine, cyclophosphamide, can be very, very effective. How do you choose a treatment? It's very individual. You might want to know what your pattern of myeloma is. Are we worried about side effects? Have you a neuropathy, a problem with your nerves, your legs, the nerves in your legs or somewhere else? Would you prefer tablets or injections, or which is better? Are your blood counts able to manage the treatments? Clotting risks can be relevant, and now we obviously take precautions that virtually everybody with myeloma will be on some form of medicine to minimize clotting risk. Usually aspirin now, but sometimes, and particularly at the beginning, some form of either a tablet increasingly, but previously it would have been an injection of a low molecular weight heparin. And then there can be practical issues and cost. The autotransplant concept, as I said, is old-fashioned, is the sense that if old-fashioned chemo can be effective, which it is in myeloma, if you give some, it works. If you give more, it may be better. And despite our best efforts internationally to, so to speak, show that the new treatments would be at least as good as or better than a stem cell transplant, it is still the case that to get the best quality remission, which will remain free of further disease activity or progression over a number of years, for certainly younger people or people who can have a stem cell transplant, that still offers the best chance to do this. And as I say, there's ongoing work all the time internationally to hopefully have to do stem cell transplants less and less. But at the moment, the reality is that for the vast majority of people who are able to have a stem cell transplant, it still has to be considered as a piece to fit into the program. And again, it can be confusing because these are just all the names that I've had people come back to me and say, I was told about a transplant, using your own cells, bone marrow. It's usually blood stem cells we use. High-dose therapy, that refers to the high dose of chemo. Allogeneic is important in that that's a word used for a transplant from a donor. And we would normally only use a very small number of donor transplants for myeloma. We do a small number. And we can come back to that point if it comes up during the day at any particular stage. But the vast majority of myeloma patients, you don't use a separate donor, you use their own cells. I'm going to skip this bit, but I just want to make a couple of points in questions that come up. Is it more likely that if you have a stem cell, you get a better response? The short answer to that is yes. Should you have 1 or 2 transplants? Well, anyone in the room who's either cared for, lived with somebody through a transplant or has had one will know that unless you really want to have 2, you try and avoid it. And I think nowadays It's fair to say, despite some important international clinical trial data which would predate some of the newer medicines, that in the context of the newer medicines, for the vast majority of people, 2 procedures is not normally necessary, with one important exception, that we, if possible in younger people, have enough cells that we could do a second one at some point into the future and combine it with newer treatments in the future. And then there's a small number of myeloma patients with a particular type of myeloma where perhaps 2 procedures, perhaps, might be better, but even there that requires discussion. It very much, in terms of side effects, they are significant. Upper age limit, it depends. One of the advances actually in the last few years are by collaboration. Anybody who's been through the stem cell process will know that we will ask people if they agree to allow their information to be reported anonymously and confidentially to the European registry. Well, I have to say now, good news, one of the important benefits of that, and we've contributed over 1,000 reports to that, we were part of a very important study, thanks, which showed that if you reduce the dose of melphalan to 140 rather than 200, that's a 1/3 reduction. For people certainly who are a little bit older, you get just as good a result. And that means for people, let's say in their mid to late 60s, who are otherwise young and fit, having a 140 rather than a 200 gives you just the same result. And that's a huge practical development. And we wouldn't have known that if we hadn't contributed that information. So I'm going to skip residual disease because I think it'll come up later on, but I just want to conclude by making the point about the majority of our patients, as I said, who are fit people in their later 60s, 70s, and 80s. And one of the great myths of this disease when I started was, I remember seeing myself, somebody who was otherwise fit, well, living independently, happened to have a chronological age of 84, and they had myeloma, and people said, well, that's it, there's nothing we can do, and that's the end of it. That's completely not the case now, and we all have looked after, and very well, we've seen people diagnosed with myeloma, as I say, at 79 or 81, do incredibly well. The trick is to use the same medicines that I've just mentioned, but to reduce the doses and give them a little bit less frequently and make other practical adjustments and keep going, go low, go slow, and go on. In other words, you adapt the treatment for that person. Don't be constrained by the official dosing for cycle 1. The trick is let's get going and get in cycle 1, 2, 3, 4, 5, 6, 7 at a low and sensible dosing. So it's good news. And to me, the most exciting piece of news when I looked at the national, we're doing a project on this, the ongoing project with the Irish Cancer Registry and our outcome data in Ireland, is the huge benefit in long-term survival, in other words, living much longer for people over the age of 70 in Ireland with myeloma in the last 7 years. And that comes from proper use of these medicines in this important group. Finally, I'm on the right, there is a long list of medicines here, and these are all really where it's at, and there are lots more options. And I know that Siobhan is going to talk in much more detail, and it'll be fascinating in terms of future directions. So for this opening talk, I wasn't going to go into what to do at the next step. Step 1, you've had your treatment initially. Step 2, which for most all people with myeloma is part of the long-term course, is what to do next. But this is just a list of medicines that some or all of you may have either heard of or may have personally encountered. Within that list, obviously, apart from the cousins of Velcade, which have been like Carfilzomib and Ixazomib and Ninlaro, which have been very, very helpful, the big development is just the medicines like DARA, D-A-R-A, the monoclonal antibody. This is an immunological treatment, and I think we already feel very soon that this will be part of everybody's treatment, probably at the very beginning. And we're just not quite there yet in terms of the practical implementation of that and certain kind of clarifications, but outside trial settings. But I think there's no doubt that for most people with myeloma, adding in DARA to their treatment at a relatively early stage is going to be extremely important. And then the other item which is not on this list is other cell therapies which are not yet approved, but I know we can certainly talk about, such as CAR-T. So in summary, myeloma, yes, it's a rare cancer, but looking at the number of people who've taken time both to be here in the room, and it's fantastic, I know, to have this hybrid meeting where a number of people are online. And as I said, there are now several thousand people living with myeloma and their families in Ireland. Causes remain unknown. It can be difficult just to understand this diagnosis and to plan treatment, but treatments have improved enormously, particularly in the last decade, and we're very optimistic all of us working together, and this means everybody in the room as well as the medical and nursing and scientific and laboratory and other professionals, and if you like the system internationally working together, we can continue to make enormous progress. So I'm going to stop there. It was just to give an initial introduction. I'm very happy. I don't know whether you want to do the questions at the end of the overall session or now, whatever I'll be guided by. Thank you very much.
Thank you very much, Professor Brown. That was extremely informative, as always. So, any questions for Professor Brown? There's a roaming mic.
Hi, thank you very much. Very interesting talk. I was just wondering if screening is something you're looking at, because there are probably lots of people out there walking around like I was with myeloma and not knowing they have it.
Yeah. I mean, absolutely. And I mean, you know, we know a little bit from doing laboratory tests in, so if you look at people over 65, for example, the monoclonal band or the paraprotein that we mentioned, at a very low level, a bit like the MGUS, you can detect something like that in actually 1, 2, or 3% of the population over the age of 65. And again, fortunately, I know Siobhan has a particular interest in the future potential of this. I think up till now, the objection has been that at a practical level, because we didn't have an effective treatment, if you were to mass screen the Irish population, as I said, at that percentage, you would have thousands of people diagnosed with tiny proteins, the vast majority of whom would never actually develop myeloma during their lifetime. But you're raising a really important point, and I think with newer technologies and newer platforms and systems and cheaper ways of doing this actually in large numbers, but importantly, knowing what you would do with the information, how that would be discussed and presented, I think we're going to see this. It's logical, and it's a matter of how we do it. So it's a really interesting question.
Any other questions? I just have one in relation to, you mentioned about COVID, obviously,
yes.
And vaccinations. Could you comment a little bit?
So, I mean, we've all been learning. We knew from day one, just to say a little bit about COVID. So we were very nervous, obviously, as well, about COVID and its implications for people living with myeloma specifically, because we knew that antibody levels, as I said earlier, in myeloma tend to be low. And we knew that you need those to fight COVID. But we also knew that what we call the T cell, that's the other part of the immune system, was likely to be important. And we knew that medicines like Revlimid can actually boost or help that. So we really didn't know what was going to happen. And certainly we did have, and perhaps some people here may know this, a number of people who got quite sick in the first and second wave of COVID who were living with myeloma who got it. And then, of course, we got vaccines. But we also knew that vaccines in myeloma may not work so well, at least in theory, because of the antibodies. And many people with myeloma will have been told over many years to get the flu vaccine. And what's interesting about the flu vaccine was, although it didn't work perfectly, it certainly provided a benefit, perhaps better than we would have expected in myeloma. So we knew that as well. So basically, the good news is there's been some very good studies now, and probably you could arguably say the benefit may be about 50 to 60% of what the so-called normal population might get. There's probably a bit more benefit now than we expected possibly to do with T cells. It's not perfect, and certainly I would recommend that getting, in the totality of the Irish way of vaccination, 4 vaccines, if you go right back to the beginning, 1, 2, 3, 4, makes a huge amount of sense to get the maximum. And obviously we're all waiting to see what will happen in probably 3 to 6 months from now. Hopefully at the moment, because of the current variants of COVID, Omicron, and the people have read about BA 1, 2, 3, 4, and so on, you know, we're all hoping that that's where it's at. I think the other hugely important development, though, is that we now have treatments. When we started, we had no treatments. And for us, certainly, this time around, we had, some people may know, a medicine which is not perfect called remdesivir, which has to be given by infusion or injection. But even that started to show significant advantages in people where the same virus type of COVID earlier on would have been a problem. And then now, of course, we have medicines like Paxlovid, for example, the tablet. And we do think the analogy for us would be if you get if we thought you were going to get shingles, many people, or herpes virus, many people who have been living with myeloma will take a medicine like Valtrex or valacyclovir or acyclovir, it just depends, but something like that. And that's been, when I started, we didn't have that medicine, and people used to get terrible problems with viruses like shingles, those kind of viruses, or chickenpox, that kind of virus, which could make them incredibly sick. But because we have Valtrex, you just say, look, take 2 or 3 and take an extra 3 or 4. So we hope we can do the same now with Paxlovid and similar tabs. But I think, to be truthful, we're still learning and we just need to watch it. So it's much more optimistic.
Post-transplant, the
Yeah.
timing of vaccination.
Yeah, I mean, we've always known that it takes 3 to 6 months after an autologous transplant before you're likely to get a decent benefit. So personally, at the moment, we would certainly recommend revaccination. With COVID, we brought that forward because of the urgency in some cases, just when we didn't quite know what was happening next. But anyone you should assume, even if you had, let's say you had 2 vaccines and then you had a stem cell transplant, it's probably better to say, I'll start again. Now, there's a debate about that as well, but I certainly would see no objection to saying, right, I'll get 1, 2, or maybe 3 vaccines, not, over several months, obviously. There's a little bit of discussion about that. And one of the questions, the final, not to delay this, but people sometimes say, well, if I measure the antibodies, or can I measure my antibody response? The problem with that information in real world terms is it doesn't really help us, because we definitely know there are people who are well protected. The same goes for flu vaccine and myeloma, who actually don't have much measurable antibody in their blood sample, but they do have a benefit. So I wouldn't rely on that. I think you just make a decision. So the vaccines are safe, so I personally would recommend, if you've had an autologous stem cell transplant, having at least 2 more vaccines, no matter how many you had. And you could discuss with your own doctors or nurses whether it should be more than that. It'll depend a little bit later in the year.
Thanks.
Yeah, we would be very cautious about live vaccines because your immune system may not handle a live vaccine. There are neither, just to be clear, the flu vaccine and the COVID vaccines are not live vaccines. They're what we call, especially the COVID ones are actually deliberately constructed, as we know now, by mRNA technology. There are situations where you can have a live vaccine, but that should certainly be discussed in some detail with your own medical team, because there can be problems with that.
Yeah, just a question. On the man's problem, is it common with a particular or certain race than other race? Because seeing this crowd, and there are a lot of, I'm the only Africa person, is it common with the white people than the Africa people?
It's a very interesting question. In fact, when I worked in the United States, and people have studied this, so in fact we had observed and always felt that there was a higher frequency of myeloma in African Americans, and in the US terms in the black community. The really interesting part of your question, though, I think, is if you look from, and again, Siobhan Levy may have a view on this, what we call the natural incidence of myeloma in, let's say, Africa, it actually may be lower. So there's something about the environmental challenge, depending on where you live, that may play into it as well. Now, so this is actually a really important area of research to try and understand that. So in the US, yes, more common, and unfortunately, historically, certainly, let's say in the black community in the US, if people had myeloma, they didn't do as well. And partly that was because understanding how to use the medicines is a little bit different, actually. And that's a really important point. But in terms of the spread of myeloma, or the frequency, let's say if you live in Africa and grow up in Africa, it's actually can be lower. But there are other reasons for that as well. So it's a really interesting question.
Can I ask a question?
Certainly.
Just for somebody, I've been living with myeloma for 12 years now, and so I have been through nearly all of the treatments that
Yes.
have been listed. So I'm wondering, like, when for some treatments that have worked really well for me and then stopped for some reason or other, is it possible to go back on a treatment that you've already used?
Yeah, I'm really glad and first of all, it's great. You're very good to share your experience of living, and I'm conscious in a room like this sometimes, but it's really important to hear this. And, when I started, I was taught that, what I was told was, let's say I started somebody, putting it in modern terms, on Revlimid and Velcade for their first treatment, and then the program says you get it for 4 cycles or 6 cycles, you have your transplant, and then you get, let's say the program said you get 1 year of Revlimid and you stop. We would have been told, well, there's probably not a huge benefit in using, or even more so, your condition started to reappear. By a blood test, by the biochemistry. Traditionally you'd say, well, that's resistant. I think one of the really important things we've learned, and the science supports this, is that in any one person in myeloma, you actually have lots of different little subtypes, what we call clones is a word sometimes used. And it may well be that, let's say you had 3 different clones, they'd all give the same superficial blood test to the doctor or the person who's looking at your condition. But one of those clones may actually still be very sensitive to, let's say, Revlimid. One might be more sensitive to Velcade, and one might need a different medicine. So now that we've rethought this, it actually makes a lot of sense to consider carefully, and that's why you must look in great detail at each person's own experience of exactly what happened, and if possible link it to the kind of scientific testing that people like Siobhan, who I know is there somewhere in the audience, are doing to sort of try and understand that better. So I would say yes is the answer. You can reuse, and often combining it maybe in a slightly different way. So I mentioned earlier on the older medicine, cyclophosphamide. If you didn't get that first time, I don't want to personalize it, but if you just take in general, that wasn't given the first time, funny enough, just adding that in to a medicine you did have earlier on could make that work very well. Or let's say the DARA medicine, if you didn't have that previously and you add that back with one of the others. So we really need to think quite carefully about that. So it's a really good question, and therefore it offers constructive optimism that have I run out of all the, I put up a list, and oh my goodness, have I run out of all the treatments? And I know this is such an important question for quite a number of people in the room, because we know we're always waiting for the next development. And it's a really hard question sometimes, because we're hoping, will I get the next medicine? But sometimes creatively reusing in a different logical way, but based on that person's history, and that's the important thing, would help. So yes.
Thank you so much, Professor Brown.
Our time is
appreciate
conscious.
that. Sorry. Now, I just want to check the room temperature. Is it a bit chilly? Yes. Yeah, okay, so I'll sort that one out. So I'd like to introduce now our next speaker. It's Professor Siobhan Glavey. She's a hematology consultant in Beaumont Hospital, and she's also a professor in pathology in the Royal College of Surgeons. So thank you.
Hi, good afternoon, everyone. It's such a pleasure to be here in person and not having to see patients with a mask on, as Professor Brown said. He's a hard act to follow because he's the godfather of myeloma in Ireland, although he's far too modest. I lost the word, modest to say it. So the kind of work I do wouldn't be possible without him. And the last time I gave a talk here, I was his registrar, and that was in 2017. So things have moved on, thankfully, in myeloma a lot since then. And he has set up my talk really nicely because he's introduced already the kind of standard treatments. So I will go through that, but talk more about kind of new therapies and what they are and when or if we may be able to access them. But also, I think it's really important for patients to understand how those drugs get into the country and what we can do to get them into the country and what that process is, because I think patients don't have a good understanding, and there's a lot of patient power behind groups like this that can help us to lobby for drug availability. So I'm going to talk about when do we need to treat multiple myeloma, and already Professor Byrne has talked about this a little bit. Treatments for newly diagnosed patients, including upcoming new treatments that will be available in Ireland soon. Treatments for patients with relapsed myeloma, so myeloma that has come back once or twice or 3 or 4 times, or even we have some patients who are on their 7th, 8th, and we have one patient, I think, where I work that's on their 9th line of treatment. So every patient is different, and everything is different within, the journey of that patient. And then we're going to focus a little bit more in my talk on new and upcoming treatments for myeloma and where we are right now for that. So you are the patient, and so you will know this better than me. What is the consequence of this disease in your body? And most of those consequences, this is a kind of a medical slide, but most of those consequences come from 3 different things. A protein is made that shouldn't be made, a cancer protein. the immune system becomes deficient as a result, and the bone marrow doesn't work as a result. And because of those three problems, it ends up that the kidneys don't like the protein, so they start to fail. And in some patients, they may require dialysis either in the long or the short term because the kidneys are totally overwhelmed by this cancer protein. Some patients can get nerve problems from myeloma, not from the treatment, because we know some treatments can cause nerve problems, but some patients can get nerve problems from myeloma. Most patients with myeloma have some or other form of immune deficiency, and the commonest cause of serious problems, including death in myeloma, is infection, and that's something that is people are probably not aware of. So infection is a huge issue for myeloma patients, and immune deficiency is a chronic state. Even when the patient is in remission, their immune system is not normal, sometimes even as a result of the treatment that they have received. Bone marrow then is where it's our factory for healthy blood, so we make all of our healthy blood in the bone marrow. And if your bone marrow is busy trying to fight myeloma, or myeloma has taken over the bone marrow, then the bone marrow is not able to do its job. And so you can't make red cells, you can't make platelets, you can't make white cells, and that's why you might need blood or platelet transfusions at various times, because your bone marrow is not able to do that job. But as well as doing that, the destruction of the bone that Professor Byrne talked about is a big problem, and that's because myeloma as a cancer is able to eat away at the bones, so it's able to create holes in the bones, and a very good treatment for that is radiation if we can find that problem before it leads to a fracture. But as you will know, many patients present with fractures. That's how they find out they have myeloma. They may fracture their hip, or they might fracture another bone, and that's what we're trying to avoid happening, because obviously that leads to an awful lot of pain and disability for patients. So this is what it looks like in the bone marrow. We all have normal plasma cells. We're supposed to have normal, small, tiny amount of normal plasma cells. They would be the cells that make our COVID antibodies, for example, or they make our vaccine antibodies. So they're good cells when they're doing what they're supposed to do, but they're very, very bad cells when they're doing what they're not supposed to do, which is when they become cancerous. And instead of making good antibodies like COVID antibodies, they start making a bad antibody. And that is what is the paraprotein. That's the protein that you're measuring in the blood each time. So when you go on treatment, the idea is that you want to reduce that protein and therefore reduce the problems that it can cause. And Professor Byrne kind of brought you through this already, but we think in most patients go on a journey from an early MGUS problem to what's called smouldering myeloma and then full-blown myeloma, okay? And I include this here just because this talk is about treatments. At the moment, we only treat myeloma at this stage. So we treat myeloma when the person has developed organ damage. So you'll see the difference between these three sections here is basically organ damage. And what we mean by organ damage is low blood counts or bone problems or kidney problems. So even if we detect a little bit of myeloma, we wouldn't treat it unless there are organ problems. And that's the same internationally. But there are now clinical trials, and there's a clinical trial open in Ireland at the moment looking at whether it's worth it to treat patients at the smouldering stage. So they have got quite a few abnormal plasma cells in their bone marrow, but they haven't yet developed the kidney or the bone or the blood problems. And so the jury is out internationally as to whether it should be treated at an earlier stage, is essentially what I'm trying to say. And so at the moment, we will only treat patients if they have developed multiple myeloma unless it's in a clinical trial. So these are the issues I'm talking about. We call them CRAB issues: calcium, renal, anemia, or bone. Those are the four things that we're looking at every single time you come to an appointment. Whether you've started treatment or whether you've been on treatment before, we're looking for that end organ damage. And if we see it in the beginning, we treat, or if we see it again in the future, we treat again. So sometimes patients will ask us, when do we treat it, or when do I need to go back on treatment? But what we're looking for is these four criteria, one of the four, not four of the four, but one of the four. Once we start to see those problems happening, we know the myeloma is active again, and it's probably time to go back on treatment. So current treatment strategies for myeloma is getting more and more complex, and I really don't want this to be a really technical talk, but you can't really talk about myeloma treatment without getting technical because it's very complex right now. Thankfully, because there are now 23 drugs approved in Europe for myeloma, and we have in Ireland, I think maybe 16, 17 drugs approved for the treatment, but that would include much older drugs like Thalidomide and other drugs that were approved for many, many years. So the principles of the treatment, what are we trying to do when we treat myeloma? We're trying to stop the production of those cancer cells. We want those cancer cells to stop multiplying. We want them to go away. And there's a number of different ways that we can do that. So it used to be, as Professor Brown mentioned, chemotherapy in the same way that we use for other cancers. It was kind of like a domestos type approach, as it is in many cancers still to this day, that you apply something that is globally toxic, but it kills off the bad cells. But it might also, destroy the carpet, for example, if you pour some bleach there. So it's kind of like an almost like a domestos type treatment, and that's an older concept in cancer. So we're trying in all cancers to move away from chemotherapy in what's called chemotherapy-free approaches. And a lot of you will have had treatments that don't involve what we call traditional chemotherapy. That means that there'll be less toxicity and less long-term problems as well. So I'm going to talk in a little while about what we're using now instead of chemotherapy. We want to strengthen the bone and prevent fractures. So even if the patient has never had a fracture, we know that they're at risk of bone fractures, and that's why we give that bone strengthener every month for the first 2 years after diagnosis, and then every 3 months for the rest of your life, unless, or up to 5 years in some case, unless it causes problems with the kidneys. The reason for that is to strengthen the bones, but it's also been shown in a UK clinical trial from about 10 years ago that actually people who get bone strengtheners do better. So their myeloma in some way treats the myeloma, and I'm not going to get into why that is, but bone strengtheners are really important, not only to prevent fractures but also to help the plasma cells stay quiet. We want to treat anemia and reduce fatigue, because if you have low blood counts, you're going to feel tired, weak, short of breath, and your quality of life will be reduced. So we want to treat the anemia initially with blood transfusions until the treatment starts to work, and then the bone marrow comes back, and then you make your own blood. So we either treat it with transfusions or we give the treatment that eventually makes the patient have their own blood back. We want to reduce the risk of infections and, most importantly, promote well-being and quality of life. So there's no point having the best available drug in the world if you can't get out of bed every day. And actually, I've had that experience with one drug, which I won't name, which is not available in Ireland, which I accessed for one patient who was in a couple of years ago, who was in a difficult situation. She had many lines of treatment, and she decided that we would try to access this drug, and we were lucky enough to be able to get the drug. And when she came back to see me after the first week of the drug, she told me she hadn't gotten out of bed for the week. She was vomiting all week, and we had a discussion, and it was a good new drug as per all of the available literature, but it didn't suit her, and there was no quality of life, so we discontinued it. And we had a conversation. She made that choice, and she was right to do so. So having the best quality or having the most fancy drugs or the best drugs in the world is not the answer. The answer is to have the right drug with the patient at the right time, and to make sure that you are communicating with your doctor and making sure that you're telling your doctor about the symptoms that you have. And always I give a big slap on the wrist to patients who wait for their day ward appointment, because if they're sick at home and vomiting for 3 days and they're really dehydrated, and then they come into me on a Tuesday and they've been vomiting since Friday, they're not going to get a sympathetic response from me, because I want to hear from them on the Friday or the Saturday, rather than letting your kidneys get dehydrated. But some people don't want to put themselves through the nasty experience in Ireland of going through an A&E department. But we try to educate patients that you should act early on symptoms, so that treatments, then maybe we'll have less treatment breaks, and treatments will be better suited. So that's what I mean when I say no one size fits all. It's becoming increasingly complex, even for experienced myeloma doctors, to be able to pick out the right time to combine treatments, and when is the time to best use the treatment for that patient. So it's very much tailored to the patient in order to maximise the benefit of the treatment, but minimise the toxicity and minimise the side effects. So this is how it looks for us and the patient at the beginning. The patient is at the centre of everything that we do in terms of trying to decide what is the right thing to do. So we look at the disease factors, we look at bone and kidney disease, we look at pain management, we balance that with quality of life and manage the side effects of pain medications or treatments. We talk to patients about their social circumstances, who are their dependents, do they need to work, what's happening with their, we work with our social workers and our specialist nurses to find out, are there financial implications of cancer? Because of course there are, and some people are unable to work as a result of their cancer, and their occupation is affected, and their quality of life in terms of hobbies. The number of men that ask me, when can I go back playing golf, or when can I have a pint? Just, and those are all, that's what it's all about. That's what, it's not about being a good patient. It's about making sure that your disease is in the background as much as possible so that you can live your normal life. What are the expectations of the patient and their family? So some patients, are content not to, for example, pushed things very, very far because they're worried about their quality of life, or they might not want to come and have a treatment that's once a week, for example, if they live 2.5 hour drive from the hospital. Whereas other patients might say, no, I want to do this differently, and they may take a different approach to treatment. So all those things have to come into play. But the truth is that the treatment of myeloma is a conversation between experts. The patient is the expert in themselves and their life, and we're just here to try to place the treatment at the right place and explain to the patient what their situation looks like. But inevitably, there's no getting away from what the disease does. So it starts at an asymptomatic phase where most patients don't know they have the disease, which is either MGUS or smouldering disease, which I talked about earlier. Eventually it becomes symptomatic, and that's when most patients become aware they have the disease. So most patients don't know they have the disease until they develop that end organ damage or symptoms. This is where the first treatment happens. So this purple line here is the protein. So the protein is low, then it spikes up, it gets high, and that's when the symptoms start. When it gets high and the symptoms start, we start treatment, and that brings the protein down. And then the idea is that the patient gets a long remission, hopefully as long as possible, but eventually in most cases the protein will start to come back, and this is when we start second line treatment, and so on and so forth. So while that's going on, in the background it's having effects on the bone marrow, and of course there can be additional side effects as new treatments start. So this is what previously treatment for multiple myeloma looked like. The frontline treatment, what we mean by that is the treatment that you get when you're first diagnosed. That's frontline treatment. Is called induction, and that used to be with thalidomide and steroids, as Professor Byrne mentioned, and then that kind of remission, getting into that first remission, was consolidated with a stem cell transplant. And then patients who had relapsed disease had some form of rescue with chemotherapy or thalidomide or other drugs, but the options were limited, and this has changed dramatically. So the current treatment sequence looks more like this. So in induction we now use 2 to 3 drugs, most commonly 3 drugs for patients who are younger. What I mean by younger is under the age of 70 or so, where they may be looking at a stem cell transplant. Most patients will get 3 drugs, and it's a combination of things like Velcade, Revlimid, daratumumab, cyclophosphamide, steroids, and then some patients will go on to have a stem cell transplant. A stem cell transplant is only of benefit if the patient is fit for the transplant and it suits them medically, so that they don't have other things that the stem cell transplant could really disturb, for example, serious cardiac problems or lung problems. So sometimes patients say, oh, would a stem cell transplant be better? It's not better if it's not better for you. It depends on the patient. It depends on their other medical problems. So in the patients who are selected for it because it's the right treatment for them, they do very well. But if patients who were to get stem cell transplants where it's not suited to them, they could do very, very badly. So it's not for everybody, and just because you don't get a stem cell transplant does not mean that your myeloma will do worse. If it's not the right treatment for you, it's not the right treatment for you. So that's something your doctor will go through with you very carefully. Maintenance then is what happens after the transplant, and that can be nothing in some cases, but in most cases we try to give maintenance with lenalidomide, which is a tablet that is taken for 21 days, 7 days off, 21 days, 7 days off, and we do that for usually 2 years. And in some cases we use Velcade or Vortezumib in that situation as well. And then in relapsed disease, there is still the treatments that have been used up front. Some of these treatments are not, for example, Elotuzumab is not available in Ireland, but we have a very, very good drug called daratumumab, which can be used in this setting when the diseases come back again. And then I'm going to talk about some of the newer types of treatments that are coming online for the rescue of relapsed disease. And that can be when it's back the second time or the third time or the fourth time or the 9th time. So it depends on the patient. But we have a certain set of rules that we have to go by for patients in first or second or third relapse, in that we have to use, we're mandated by the National Cancer Control Programme as to what drugs we can use at what time. But I do think we're fortunate in Ireland in that we do have reasonably good access to drugs compared to some of our European partners, but there's never enough. So I think we need to keep working on that. So looking at the relapsed patient then, there are a couple of other things that come into play at that stage as to how you're going to pick the treatment for that patient, how you're going to choose that with the patient. So first you have to define that the patient has relapsed. Have they relapsed or not? Do they have any of those things that I talked about, the kidney or the anemia problems or the bone problems? And then you diagnose the relapse. And then you talk to your patient and ask the patient, what is your preference? You know, are you able to travel to the hospital once a week? Would you prefer not to do that? This is where your disease is at. It's rapid or it's not rapid. We have to talk to them about how the disease is looking. And we look at a risk assessment for the patient and also for the disease. So we look at, is it in the bones, is it in the kidneys, or is it something that's a little bit slower and kind of slowly building up, and therefore the patient may have a little bit more time. They might say, look, I want to go on a holiday, or my daughter is getting married, and I'll start my treatment when that's done. And sometimes we can do that in the relapse setting if the relapse is very, very slow. And then we pick the treatment. But when we pick the treatment, we have to think about what's available for that patient at the time, what other treatments has the patient had in the past, and can they be used or should they be used again, depending on how long the time was between when they had it and how well it worked. What was their response to the treatment that they had in the past, i.e. did they get a really nice long time where they responded really well, or did they have a treatment and while they were having the treatment within a year or 18 months the disease came back? In that case, it's not likely that treatment will work again at that time. But sometimes we can get the patient back into remission by just adding in something. So those are all kind of things that we think about. And the performance status, so thankfully patients are living a lot longer with multiple myeloma. So, you know, a patient who is diagnosed at 52 may not have the same performance status when they're 62 or when they're 72. So the performance status of the patient can change over time because there are other things happening too. For example, if the patient was to develop a different kind of cancer or they were to have a heart attack or something in the meantime, then, you know, the performance status, how the patient is, comes into it. So I'm going to talk now about newly diagnosed disease. So this is what happens when the patient is first diagnosed, and Professor Byrne has mentioned this already. Not transplant suitable is the best way to describe this, in that what I mean is that the transplant isn't suitable for the patient, and those patients have lots of options, including Revlimid, Vortezumib, dexamethasone, soon daratumumab up front but not yet, cyclophosphamide, and also oral melphalan. So we use IV melphalan for transplant, but oral melphalan is a very, very good treatment for patients who are not transplant suitable. These are transplant suitable patients. Then most patients will get cyclophosphamide with Velcade or dexamethasone, or get Revlimid with Velcade or dexamethasone, so RVD or VCD, and soon, again not yet, but soon we may have daratumumab in combination with 3 other drugs. So this will be the first time for transplant eligible patients that we treat them with a 4-drug treatment, because up until now we're treating them with a 3-drug treatment. And again, you know, when you put 4 drugs together, there's a possibility that the toxicity or the side effects could be worse. So that's something we have to kind of get used to as well. And then, you know, having the transplant followed by maintenance, or some patients in some countries, not really here because we have access to very good drugs, but in some countries for certain types of genetic myeloma, one transplant followed immediately by another transplant, which is called a tandem transplant, is used to try to get the patient into a very good remission. So I'm not going to go into the science of this too much, but I want to talk to you about how the drugs work, because that's been one of the reasons that myeloma cells or myeloma patients are living for longer. So this is the nasty little problem here, the myeloma cell, and what it should be doing is making good antibodies, but it's decided that it's a cancer cell and it's making bad antibodies. And in the past we used to give chemo and it would just kill the cell directly, kind of like Domestos. But what the newer treatments do is they get the immune system to kill the cell. So what they do is this is the drug, so the purple little Y sign is daratumumab, and it locks onto the myeloma cell, so it sticks onto the myeloma cell, and the other side of the drug brings in an immune cell. So these are the cells that would kill viruses, for example. So it's able to say to the immune cell, hey, come on, help me out, I need to kill this cell. and I'm way behind on time, so I'm gonna move on. But what I'm trying to say here is that these drugs are smart. They're able to overcome the immune system, but eventually the immune system gets smart and says, I'm not going to kill those cells anymore, and so then that's when the disease starts to come back. So this type of treatment is immunotherapy, and this is a really huge breakthrough in all kinds of cancers, not just in myeloma. And the nice thing about these drugs is because they're not chemotherapy, they tend to have less side effects. For example, they don't cause hair loss. The stem cell transplant then remains the most effective therapy in eligible patients and provides the best chance of a deep and durable remission. But it's not suitable for lots of patients, and it can be associated with very significant side effects, risks of infection, and it can be very psychologically upsetting and difficult for patients to go through. So those of you who have been through it will understand what it involves, but the idea is that you've had your treatment, your myeloma has gone into some form of remission, and this is the final step to push it into a deeper remission. So we give it a high dose of chemotherapy to get rid of those last kind of cancer cells that are left in the bone marrow, so that the patient can have a longer remission. And this is a clinical trial from 2009, and it was reported in 2017 and again in 2020. And what this shows is that even with the newest best treatments for newly diagnosed patients, transplant still has a very important role. And at the end of 2020, they compared transplant, so patients who had transplant are in the blue, and patients who didn't have a transplant but they had very good treatment. With a combination of Revlimid, Vortezumib and dexamethasone, had a 30% reduced risk of progression if they had the transplant. So this was really an important study because it shows that even with the new drugs, transplant is not going anywhere. It's a really important part of the treatment, and that's why we still recommend it for patients that are suitable. So I'm going to talk now about when the disease comes back, because I think that's what most people are probably interested in. This is looking at the European Medicines Agency approved therapies for myeloma up as far as now. Okay, so frontline we have thalidomide, bortezomib, lenalidomide and daratumumab in combination with lots of other drugs. Now this is not in Ireland, this is in Europe, but most of these are approved in Ireland as well. And then in the relapsed setting we have bortezomib, lenalidomide, so patients may go back on a treatment that they had before. And that's not a bad thing, that's a good thing. If you respond to a treatment that you had before, it means there are more things left on the menu should you require them in the future. So going back on something that you had before, if that's the right decision for you, is actually, I think, a good thing. And then there are lots of different types of bortezomib now, like carfilzomib and ixazomib. Ixazomib is a tablet form that has been useful for some patients. And the more newer drugs include very advanced types of immunotherapy, like antibody drug conjugates, bispecific T cells, and CAR T cells. And so there have been 2 approvals that are very important for myeloma in the last year. One for a drug called belantamab, which is used in patients who are what's called triple refractory. So they've had 3 different types of treatment in the past. And belantamab is a new kind of drug that I'll talk about in a minute, that was approved in 2020. And then in 2021, the first CAR T-cell, ide-cel, was approved for multiple myeloma in the US and has also due to receive it was approved also in Europe last August. So this has been now approved. And again, this is just showing that the cancer cell on its own is very complex. So here's the cancer cell, but this is all the stuff that's going on around it. So it's really complex, and that's why we're able to develop these drugs, because scientists have come to the point of understanding exactly what's going on in the tumour. So I'm going to talk about bispecific antibodies. Now this is I don't want to get too technical on this, okay, but I do know that some patients want to know more about belantamab and about these drugs because they are very important new drugs for myeloma. So they're called BCMA, bispecific antibodies. And I'm not going to get into the complexity, but what I'm going to say to you is they work a little bit like daratumumab, but what they do is they bind to a special protein on a little area on the cancer cell. So this is the blue blob here is the cancer cell. And they are also binding to T cells. And what they do is they create a very smart kind of portal between the T cell, and the T cells are the ones that kill the myeloma cells. So they're very intelligent cells, and the short name for them is BiTEs. And there are 3 BiTEs that are either about to be available on some limited capacity or not yet available in Ireland. One of them is called belantamab, and the others are elranatamab and teclistamab. And we have just treated a patient with elranatamab, but the availability of these drugs is not quite there yet, because they're still in very early phase clinical trials, and it needs to be proven that they are safe and that they're effective, and they're also incredibly expensive. And that's the same for all cancer drugs. That's not just for myeloma drugs. So, we have to be really careful that they are the right drugs for the right patient at the right time, and that they're used in a good way from an economic point of view. And that's something that the government looks at when they're trying to find out what myeloma drugs are going to come into the country. So that is a part of it. And so the other one then is, belantamab is an antibody drug conjugate, so I'll just talk about that now. So some of the antibodies are linked to chemo. So they have an antibody on one side that gets inside the cell, and it carries a little bit of chemo into the cell, and that's what belantamab does. And so it comes inside the cell and kills the cell in a different way, and that's a very smart thing to do as well, because it's only going to the cancer cell. So it's like having a little envelope that you post into the cancer cell with chemo inside it. Rather than giving chemo to every cell, you're only putting it in the letterbox that you need it to go into. So it's a really useful way to kill cells, and belantamab is not available in Ireland at the moment, but we hope that it will be soon. So now I'm going to talk about CAR T cells. Professor Brown probably knows a lot more about this than I do, because if they do become available in Ireland, and hopefully they will, it's likely that it will be through St James's Hospital, because they are the experts in allogeneic transplant. And so what this involves is a little bit of like the transplant, in that the patient has bloods taken, a large amount of blood, or not a large amount of blood, but a certain amount of blood is taken off, and the T cells are taken from the patient. And then the T cells are brought into the lab, so your own T cells are brought into the lab, and they're manipulated in the lab to kill your own myeloma cells. So essentially the T cells, which are our immune killer cells, they're there to kill viruses and bacteria and other things, are brought into the lab, and they're educated to kill myeloma cells. And then they're put back into the patient, and then they go about their business of killing myeloma cells, which they wouldn't have been able to do before they were changed in that way. So it's a form of kind of genetic engineering in a sense. And there's an awful lot of buzz about CAR T cells in myeloma. But I think they are what we could consider at this point a prototype. So I don't think that CAR T cells will, in their current format, will roll out very, very broadly internationally. But I think versions of them, as they become available over the next 5 to 10 years, certainly will. But I think the bispecific antibodies and the antibody drug conjugates that I talked about, that target similar things, are very, very promising in the more short to medium term. And so this is another complex graph that I'm not going to go into, but it's just to show that they do similar things to the bites. So what they do is they get the cancer cell, they go to the cancer cell, and they bring the T cell along, and they say, kill this cancer cell. And I have to talk about this drug, which is Venetoclax, because we've done a lot of work in Venetoclax in our research group over the last kind of year and a half. Venetoclax is a drug that's available for another kind of blood cancer, and the reason I'm talking about this is because Professor Brown mentioned about the genetics of the cancer, and the reason so many patients of different ages have myeloma and have different types of experiences, and it affects different things in different patients, is because the genetics are different in different people. So the genetics of the cancer is different in different people. So we probably need to find people who have similar genetics and get treatments for those particular groups. It won't be that one drug really cures myeloma, but it might be that one drug cures a certain genetic type of myeloma or gives a very, very good response. And so Venetoclax is one of those drugs, and it will probably be licensed for myeloma later this year, and it will be the first treatment for myeloma that's targeted to a molecule that's actually targeted to myeloma inside the cell. And I think probably there's a study going on at the moment to find out what percentage of myeloma cells overall, or patients, overall might benefit from this drug. Probably about 30% of patients, but it's not known yet. So this drug is not going to be for everybody. It's going to be for patients who have this specific genetics signature. And in those patients, it's expected that it will work very well. So what I'm trying to demonstrate here is that we're getting now into the nitty-gritty of dividing patients into different genetic groups and giving them treatments based on their genetics, which has never happened before. And then I'm just going to talk briefly about clinical trials. So I think there's a perception that clinical trials are a bit of an experiment and kind of a little bit of a leap of faith, but actually clinical trials are absolutely vital for getting new drugs into the country for myeloma patients, and they give access to drugs that patients wouldn't otherwise have access to, and they are either going to be the standard of care or the standard of care plus something. So the patient will never be getting a treatment worse than what's available to them already in the clinical trial. It'll be something either that's proven to be the same or better usually. And so they are excellent choice for patients with limited options, but they're just not enough of them. There's not enough of them open in the country, and patients have a voice in order to make myeloma more known about. And I don't want to anymore diagnose patients with myeloma who've never heard of the disease, because you don't diagnose somebody with breast cancer who's never heard of breast cancer. So why should myeloma patients only hear about this when they actually develop the disease? So I think there needs to be a lot done in terms of getting word out there about this blood cancer, because there won't be enough done about it until myeloma is cured. So I think we need to work on getting more clinical trials, and Professor Brown and others and myself over the years have done a lot of work to try to open clinical trials in Ireland, but it's a complex process, and patient advocacy is really, really critical to that. So patient advocacy is about engaging patients in research so that we can develop questions that matter to patients. So our job is to find out what are the problems that need to be solved, and then try to design studies that will answer those questions. But more and more, Multiple Myeloma Ireland have helped me a lot in the last year to engage with, for example, Irish Cancer Society and other types of agencies where we're trying to get more awareness for myeloma research, and that can be something that patients can help with. So I really would encourage patients, and I was delighted to hear that there's advocacy training going on. I think it would be great to get patients involved in advocacy. I know that patients have enough to be doing, getting to their appointments and things like that, but there more needs to be done for patient advocacy in myeloma if we're to really put myeloma at the front of funding. Professor Brown already talked about supportive care, but this can't be overstated. So this is the management of the complications of the disease and the management of the side effects of treatment. And this is why one of the biggest reasons myeloma patients are doing a lot better is because the supportive care has improved so much. And also preventative care, like I mentioned, vitamin D and calcium, and also your Zometa to prevent bone fractures. There's a lot of things that have to happen for a myeloma patient to be treated. It's not just us as consultants. We have a whole body of people behind us trying to help us to support the patient. So we're just a small part of a cog wheel with the patient kind of at the centre. Our nursing staff, our clinical nurse specialists, our advanced nurse practitioners, our junior doctors, our day ward staff, our secretaries, our healthcare assistants, our porters, the clinical trial staff, everybody has a role to play in caring for the patient. So it's really a multidisciplinary process, and obviously a lot of patients will have issues where they require pain experts, or maybe physiotherapy, or they might have to see a neurologist or a kidney doctor. So there's a huge amount of healthcare resource that has to go into looking after myeloma patients, and this is something that patients should be aware of and that the government should be aware of, because if we have better treatments and patients are not as unwell, then that will reduce healthcare resource use, and that money can be spent on drugs. So I think it's important to understand how healthcare resources are used within certain diseases. So I'm going to finish now just by saying that new treatments are being developed at a really unprecedented rate, and even for us it's hard to keep up with the science of how this is changing. Different treatments suit different patients, and some newly developed treatments can produce really, really long remission rates. So the drugs are getting better as well as becoming more in number. But supportive care is crucially important, and clinical trials are also crucial. So I would encourage you, to advocate for that and to make your voices heard, because the power is with the patients. We're here to kind of I suppose, treat and diagnose myeloma and to facilitate access to clinical trials, but you have a huge expertise in myeloma yourselves, and that's something that funding agencies are recognising more and more. The patients are really the experts and not us. So I'm going to leave it at that. If you have any questions, just let me know.
Thank you so much, Professor Claffey. If there's any questions now, unfortunately we've to limit it to 2 because of time constraints. I'm sure there's many questions you want to ask, but sorry about that.
Oh, I'll get you.
Thank you, Professor. what would you typically regard as a very long remission, period-wise?
Yeah, that's a really good question. So again, it kind of depends on the patients. It depends on the patient and the kind of treatment that they've had. Typically, we would be hoping after a transplant for a patient to have a remission of greater than 2 years. But some patients don't, and that's how their myeloma behaves, and then we have to, adapt our plan. But we would hope for them to have a kind of a period of about 2 years while they're on maintenance lenalidomide where their disease is not active. But obviously the longer the better. And one of the most recently reported trials has reported overall survival rates after first-line treatment of about 8 years, which is really, really, really long. And I think we're moving towards longer and longer and longer remission rates. But it's a difficult question to answer because it depends on the patient and it depends on how their myeloma presented in the beginning. But I think, with most treatments, we want to at least have a good remission rate of approximately 2 years.
Here was wondering, does myeloma affect your brain?
It can. It doesn't typically involve the brain, but it certainly can. It can do that in two ways. It can grow in the brain in the same way that it does in the bone marrow, but it can spread into the fluid around the brain, which is a little bit more common. So it can spread into the spinal fluid. It's very, very rare for that to happen. Even when myeloma affects the spine, it doesn't usually affect the brain, but it certainly can happen.
One more.
Yeah.
I'm not sure if it's for this stage, but just in relation to peripheral neuropathy, maybe induced by the treatment or perhaps by the disease, is it necessary to distinguish between the two, or can one go away if it's just the treatment that has caused it?
So it's usually the treatment that has caused it 9 times out of 10, and it can go away if the treatment is dose reduced or stopped, but it can come back if that treatment is ever reintroduced in the future, and it can be from other drugs too. So some of the new bispecific antibodies cause neuropathy. So if the patient has neuropathy from a previous drug and then one of the new drugs also cause neuropathy, we have to be really careful that we monitor them for symptoms or maybe reduce the dose if they do get neuropathy.
Thank you so much for that. Really appreciate that presentation. Now, can we present the next speaker? Her name is Byrne. She's going to present a carer's perspective. She's a carer and a mum and a very good fundraiser. She's done wonderful fundraising event for us there recently, so we much appreciate it. Thank you.
Hi there, everyone. I feel a bit out of my depth, so you'll have to just bear with me given the lovely speakers we have here today. So, as I was introduced there, I'm Ali. I'm a mum and a wife to Michael, who was diagnosed last year. And I'm a carer, which I haven't really even accepted it now because I still don't consider myself a carer. It's very easy with having a patient like Michael. He doesn't question anything, so they can give him a tablet or a drip or any course of treatment, and he's like, yeah, no problem. And then he'll land home, and I'll be like, what does it do? What are the side effects? So it can cause a little bit of friction by times, but we'll get to that. So it's a role that no one ever really wants to have, but and while you're living in it, you don't really think about it because you're in the thick of it and you're just trying to get from one day to the next. And some people might have children at home, like ourselves. We have 3 small girls, and you just get on with it a good bit. Like back in early 2021, my biggest worry was, when will he stop snoring? So Michael had severe back pain coming up to the Christmas of 2020, and he kind of adjusted and adapted things to do things around the house. And I'm not sure, most men are probably all the same. They don't go to the doctor immediately and you have to coax them a bit, but the snoring was getting unbearable. I wasn't getting a wink of sleep, so I pushed him along anyway to go to the doctor. And winding on then to about April time of last year, Michael was diagnosed with multiple myeloma. He was taken into a day ward where they had done many tests and admitted that evening after we finding out that he had cancer. They weren't able to tell us on that evening what type of cancer it was, but that it had shown up. And with COVID, I wasn't allowed in, so I was waiting in the car parks most of this time and only brought in for the main couple of sentences and then sent home again. So it was quite sudden and scary at the time, because you were just leaving him, like after hearing that he's cancer, I had to go home and leave him on his own. But anyway, he was transferred over to Tullamore, where he met a wonderful team of nurses. And again, like, the patient is given the best of care, their hands are held, they're like told everything, and you're sitting at home or in the car park waiting and getting, as Geraldine mentioned earlier, like it's half a story, or like, well, they told me this is going to, do what it's going to do and make me better, so I went along with it. And I'm like, right, fair enough. Part of Michael's diagnosis involved, it transpired in many fractures in his back and his neck. And so he arrived out to the car 2 weeks after being in Tullamore, and he was in a neck brace and a back brace and this little white piece of paper, and hopped into the car anyway. Michael is a very positive person and jolly no matter what's thrown his way. And he hops in, puts the paper on the thing, and I was like, what's that? I start my treatment in 2 weeks' time, and I'm like, what? So I kind of felt, I'm a bit of a control freak, so I kind of felt this is all happening very fast and I have no control. I don't have many of the answers that I want, because I'd be there firing questions at the doctors and the nurses, so probably it happened a bit quicker because I wasn't there delaying things as such. But yeah, he came home, and looking back in hindsight, it was amazing and brilliant that it happened so quickly, because there are many people that it takes months of scans and you're waiting then to get back on a list for another test and another test. So in hindsight, it was amazing that it happened very quickly in the space of 2 and 3 weeks, and then Michael had started his treatment. I had kind of held my breath until about last October time, wondering, because again with COVID, you're kind of out on the outskirts of it and you feel like you're not really involved. So I threw myself into fundraising, of course, as a distraction to keep me occupied and off Michael's case of asking too many questions. But it was brilliant to have that outlet as well. So the transplant and the harvest came along, and Michael is actually doing really well. The braces were thrown to one side at home, and he hasn't really looked back. He's now at the stage where he's he had his 100-day post stem cell transplant there earlier in the week. We had a little party, and he's weaning himself back to work. Michael couldn't work, and he couldn't do much, for he was in the braces for about 5 months. So at some parts of it, I was putting on his shoes and drying his feet, and for a man that was so active and everything, it was probably hard for him to accept. Also, it was something I didn't even think of. You just turn the automatic switch on and you just do it. But yeah, we seem to be out the other side of it, and we think it's amazing. We have developed a very dark sense of humour at home with our children, and anything could be blurted out at the dinner table, but it gets you through the day. You find what'll, get you through. But I have to say that if, looking back, things were frantic and were very difficult, and you're kind of feeling a little bit lost and on the outside. Obviously COVID was the cause of that, but the nurses are amazing when you do get into the hospital, and if you get in front of the consultants, you come out lighter, because they really do know what they're talking about, and if we can just trust them, it all does work out for the better. But yeah, so I still haven't accepted the role of a carer and the label of a carer, because it just feels like you're taking away someone's independence, because you're a carer for someone that needs extra support, or there's something limiting their life, basically. So yeah, I kind of put that to the back burner. But overall, looking back on it, I have actually really enjoyed the extra time that we've had together, because I had to give up work, and we got time that we never would have. Like, when is there a time where you can take a break from work and life and spend it with your husband or your wife? And obviously everyone here knows how long you can be waiting in a waiting room, or how long, the journey's over and back to the hospital. And yeah, so I have actually really enjoyed that, and it has added more to our family life. Like, we're closer and we're more resilient as a result of the diagnosis. So I think we have embraced it to a certain degree and looked at all the positives that it can bring. But I do find myself in the last 2 weeks, when I have been thinking about what would I say and what is the role of a carer and what's my perspective on it. So I have a social media page following on from the fundraiser, and I asked carers to give me their idea on how they found being a carer for a spouse. And they said it's a constant trade-off, or some people said it's exhausting, or you're constantly living on the edge. All of that is true. And it is a constant trade-off. Like, before Michael was diagnosed, we were very active. We'd go on cycles, we'd go on long hikes, we would go to the beach for the day. Now we can't go to the beach for the day because Michael he can't be on his feet all day long, it's too long. The drive there takes a lot out of him. It's all about adapting your life around it. But we've taken to cycling a bit more. It seems to be a bit more easier on his back and that, but yeah, it's all about adapting to things, isn't it? But I do feel the pang of jealousy now because he's through his transplant. He's looking really fit and well, and he's, still has all the nurses run around after him, but he's weaning himself back to his GAA coaching and his job, and I'm kind of left thinking, oh God, I have to start again. Where do I go from here? So, that's the crossroads that I'm at now, but overall, I have found the experience, whilst at the very early stages, very even traumatic, for want of a better way of putting it, and maybe in normal times without COVID it wouldn't have been as bad, but I have found it a positive experience for our family, and if we can trust the consultants and the nurses in what they're saying and that, and stay away from Mr. Google, things are a lot easier, and it makes the days a lot easier and less stressful. I don't really have a whole lot more to say. So, Siobhan, you could have probably had some of my time.
Ali, thank you so much for a very honest...
Pardon?
I said thanks so much for a very honest opinion.
Thank you.
Michael, you're a very lucky man. And maybe we need to look at the word carer. You've made me sit here and think about it. Maybe it's something that we need to look at more, a partnership. A partner maybe, or something like that. But yeah, it's definitely food for thought. Yeah. Thanks a million.
Thank you.
And now it gives me great pleasure to welcome John O'Mahony, a fellow West of Ireland person. So that's good, John. And many of you will know John from his GAA exploits and his time in Dáil Éireann, but here today John is going to talk to us about his personal experience of myeloma. Thank you, John.
Thank you very much, and thank you for the invite to, I suppose, share my thoughts and experiences after being diagnosed with multiple myeloma in the summer of 2020, so right at the peak of the COVID pandemic as well. There was a lot going on in the world at that time, lockdowns, businesses closing, schools closing, travel curtailed, and I suppose a lot going on in Downing Street as well, as we're hearing in the last few days, that we didn't know about at that time. But I suppose in my world there was a lot happening as well, in the sense that I was on the 31st of March 2020, I drove home from Dublin just after the first lockdown, finishing after 13 years in the Oireachtas. I wasn't contesting the election. Before that, I had taught for 31 years in my local secondary school, St. Athie's College, and I had a lifelong involvement in the GAA as well, so life had been pretty busy over the previous 44 years. I was looking forward to stepping back and slowing down, and the bucket list was filling up. My wife was a retired school principal as well, so if you remember, the months of April and May were beautiful weather, and I set about walking. I suppose the irregular lifestyle I had up to that, I had put on a bit of weight and maybe wasn't as healthy as I should be. So I enjoyed walking about an average of 20 kilometres a day, had lost some weight, was feeling fantastic. And on one of those walks with my wife, we kind of remarked to each other, and we awful lucky that no one in our house got sick or whatever, and children or grandchildren or anything like that. So that was, I suppose, brought to a shuddering halt in late July, early August, where I got a little pain in the back. Didn't pay too much heed of it, to be honest. I had been helping out. I'm not a gardener, but I was helping out, lifting some flagstones and stuff. So I thought effectively the pain in the back was something to do with maybe a muscle pulled or whatever. Took a few Panadol. It went away for a few days, but it came back with a vengeance the following week, and I had to go to Dublin to something, and my wife said, I'll drive you, or we have a daughter living in Mullingar, so we said we'll break the journey. But as it happened, I had to get out of the car in Longford, I think, or somewhere, just to walk about to get some ease from the pain in the back. Went to my daughter's house. I was getting some ease, I suppose, when I was lying on the bed, and dozed off. Woke, looked at my watch. I was 15 minutes late. I had timed to Dublin. Jumped out of the bed, and I'd say everyone in Mullingar heard the roar. Went into my daughter, and she's an occupational therapist, so she has some medical knowledge. And basically, I got ordered that I had to sort this out the next day. Went into Galway Clinic, rang my GP, couldn't make contact anywhere, so I decided that we'd go to the Galway Clinic. All of the tests were done within a couple of hours. MRI scans, CAT scans, whatever else. And effectively, they just sat me down and said, we see something here. So I suppose the word cancer wasn't used, and as you know, for our generation, what the word cancer means, or what it meant. I remember my mother told me about, she was from Balmullet on the Atlantic Ocean, if you like, and she told me about, when I remember it just came back to me, her father was sick, had to go to a hospital in Dublin at the time, so he went in on the bus to Ballina, went on the train to Dublin, and the next time they saw him was when his remains came home from Dublin on the train as well. So that kind of hit me, and all of this. So in other words, what I'm saying is, the most thing about all of this was kind of your mental state and how you're prepared for it. That was the background, and in many ways, when the diagnosis came, the first, I suppose, there was a bit of a shock when I thought, when I was going to the Galway Clinic to get the test done, that I'd be coming home and that I'd get the results a few days later and so on. So they said, we're keeping you, and biopsy tomorrow, and you'll have the result in 4 or 5 days. So I can say that those were the longest 4 or 5 days in my life, in that sense. And I happen to be, and your life flashes in front of you, really, because you're thinking of your children and grandchildren, and will you be around to see them growing up and all of this. And then I had many good sporting memories in my life, and actually I was on the top floor of the Galway Clinic, and I was looking out onto the motorway from Dublin, where I suppose 20 years previously, we were in a cavalcade of about 20,000 people bringing home Sam Maguire, and all of that just kind of, it flashes in front of you, and I suppose you don't want to leave. You don't, you want to be around for a while longer. So that was the thing. But I suppose what kicked in then, as a result, as we went on through radiotherapy, the chemotherapy and stem cell, was the great reassurance, and you know, where my perception of what my ailment was totally changed and reassured. And you know, I thought my journey, I knew a lot about multiple myeloma, so I've learned a whole lot of brilliant things today as well. So I realise, I suppose, how much I don't know. But what was brilliant was the reassurance, the wonderful care that you were given, and the explanation of your pathway forward. So it just totally, you know, mentally changes your perception, and that's what I found was absolutely brilliant. But I suppose those 5 days were like slow motion, in that sense. So ironically, there was a relief when I got the diagnosis on the following Wednesday, that, you know, now we're, and I suppose in my sporting mantra, if there was a difficulty or you lost a match or you were analysing your team's performance, you spent 20% of the time identifying the problem and 80% finding the solution. And I suppose what my medical people, Dr. Janis Krauchek was my consultant, and you know, I suppose the tribute I'd like to pay to, and Professor Glavy and Professor Brown talked about, you know, the teamwork and everything else, and I feel about the medical team right from the top to the bottom. The reality is that a lot of us are around in this room today because of your work and your research, and long may that continue. And I think you don't need to be modest about it, because I suppose Michael D. Higgins, the President of Ireland, seems to be writing out a lot more cheques for people reaching the century. And my wish for all of you is that you all get a cheque for $2,500? I'm not sure, but that was the way that my perception changed, and I knew it. And I suppose when I was talking to my consultants and the questions I was asking, I didn't want any sugar coating, and I didn't get any sugar coating, because you need to know what the real story is. There was a few bumps along the way, in the sense of, I was told, you know, I was visited by physiotherapists and back specialists and all the rest of it, but I was told that I'd be getting a visit from the palliative care nurse. Well, my father died from cancer back in 1996, and you know, I knew what palliative care meant at that stage, or I thought I knew, but obviously it was explained. It knocked a bump out of me when I heard I was getting a visit, but obviously it was explained of what the effects and side effects of the tablets or treatment I would be going on. So that eased me. Now the stem cell transplant procedure, I was, you know, the extraction of the cells happened in early December, and just the small things that can make a difference. I was said, well, you'll probably be in for 3 days. That turned into 5 days because there wasn't enough of cells captured on the first time or whatever. And mentally, I wasn't ready for the 5 days in hospital, and that really kind of knocked me back a little bit. So I was determined, when I was told that the stem cell, the transplant itself or the chemotherapy around it would be for 3 weeks. So I was determined, I was kind of mentally prepared for 3.5 weeks in that sense. So it was a lesson learned along the journey. But I suppose I went in just after Christmas. We had some of our children and grandchildren at home for that Christmas, and it was a family time. But anyway, I was out for a walk and I got the call, we want you in tonight. So obviously I was delighted in a way that I was going in, but I was fearful in another way because I knew it was going to be difficult. And ironically, the thing about COVID and that no visitors, in some ways it was very difficult, but especially that you didn't maybe have some family member that was able to come into you or whatever. But in another way, it was, you weren't, especially for the stem cell part of it, you needed almost to be on your own in that sense. So anyway, I got the call, but I'll never forget walking in that evening into the hospital. But it was as tough as I expected, in the sense that you lose control of your body, or there's tubes everywhere and all of the rest of it. But again, mentally, this needs to be done. I knew it was vital for the recovery, so I suppose that was the thing that superseded everything else. Just to conclude, the things that I found helpful, well, as I said already, the wonderful care from top to bottom. And I was in those days when the cases after Christmas 2020, I think there was 5,000 or 10,000 cases of COVID on those days, and you could feel the tension in UCHG hospital where I was getting the transplant, but it never in any way affected the treatment or the care that I got. And I just, you'd be bowled over by the fact of, obviously there was nurses maybe with COVID or off COVID, and there was a lot of it in the hospital and other areas, but it just bowled me over. And as a politician over the years, you get so much criticism about the health service and so on, but it's only when you're in the throes of see the way the professionalism and the care that it just bowls you over. The other thing obviously is the support group. The benefit of the support group and talking to someone in advance of the stem cell that had been through the journey as well. And my consultant gave me a phone number of a person who had agreed to talk to me, who I knew was actually a friend of mine, but I didn't know he had gone through the treatment or the cancer. And he told me he was running marathons. He had it 3 or 4 years ago. So, you get a boost and a lift from all of that. And that was crucial as well. And the support group as well. We did our support, the patients of Dr. Krajcek, we did it on Zoom, obviously. But all of the advice from physiotherapists and psychologists and all the rest of it was really, really brilliant, I would say. The other thing, I suppose, that in my case, what came up is that there would be the way I don't know is it Irish society or not, but there's a rumour machine when somebody gets sick. And I was wondering how I'd deal with this, because I didn't want, once I got the reassurance and treatment and the pathway ahead, I became confident that I was going to get through this and with the help. But I know my own perception of years. If you hear someone has cancer, you're whispering it, or a funny story on it. A good neighbour of mine would be very good friends, but he'd ring me if anyone was sick or died in the region or whatever, and you might in passing say, well, what had they, or what did it cause? Oh, he called it. Now, we've heard a lot of technical terms tonight, or today, but. The term he'd always use, I think it was the boyo. I got used of this term, so it in many ways it was funny. So, but there is a journey ahead for all of us. The other thing I'd say is that I'm glad in my own family that it was me that got it. And I can understand the care that spoke previously, because I don't think I'd be able to cope as well if it was my wife or some of my children or something else. At least when you have it, you're the first to know where you're going and where you have to go. But I think I would be a lot less able to deal with it if it was someone that was close to me. So I suppose that's a reason for, maybe in the support groups, I'm not sure what happens widely, but that maybe a network of family members as well in some way of how to cope with it would be good. I'll just finish again by saying, as I said earlier, all of us, or a lot of us here in the room, are alive because of the wonderful work of the medical people and research that's going on. And I just hope that that will continue, and whatever way we can advocate for that, in whatever way we'd be delighted to do that, because we'd like to get that check in a few years. And my wish is for all of you to get it as well. So thank you very much.
Thank you so much, John. That was a great talk. Has anybody a question for John? Or?
Yeah, I just have a question for John.
Sure.
John, who's going to win the grand prize?
Yeah! Okay, John, answer that one.
How long have you got? Well, I suppose I live, I'm from Mayo, but I'm on the border with Roscommon. But I manage Galway, so
don't forget Leitrim, John.
I won't forget Leitrim either. I'll never forget Leitrim. So I have a lot of feet in lots of camps. But Roscommon have beaten Galway twice already, so there should be huge motivation for Galway to maybe turn it over. But it'll be a very close game, but I think maybe Galway. I hope that's the right answer.
Thanks very much, John. Okay, that wraps up the morning talk. So we've a break now until 1:30, lunch from 12:30 to 1:30. Thank you.